Welcome to another Tuesday evening for the webinars on the HSG protocols run by the College of Family Physicians. My name is Suraj Kumar and I'll be your moderator for today. Today's topic is quite a big one, hypertension and multi-morbidity. And to deliver that talk, we have one of our council members, Dr. Julian Lim, who in fact is the organizer for this whole series. And as usual, we have our panel of resource persons from the college, MOH, as well as AIC to help us with the Q&A after the talk. And at the end of the talk, I will also give a brief overview for next week's session. So please still hang on until I finish that one. Okay, without much further ado, I'll hand you over to Dr. Julian Lim to start off today's topic, hypertension multi-morbidity. Julian?
Hey, hi, thanks, Suraj. I suppose you can see my screen. Yeah, good. So today's topic will be on hypertension control and multi-morbidity. I'm Dr. Julian Lim. I'm a GP practicing in Teban Gardens, and I'm a council member of the college. So this is the 8th of the series. Next week will be the last one to end off this whole series of webinars on Healthier SG. So we are almost there. It's like a marathon. It's quite painful for all of you actually, because after every night, 10:30, we finish. Well, really cannot sleep the whole night. Okay, I'd like to thank the subgroup members also for the care protocols. And we have some of them here this evening. This is just a little screenshot of those who came in about 5 minutes before. But I think some of them are actually in, and I would like to thank them for being with us tonight. Okay, before you start typing in questions, let me just go through a few things and see if what I'm going through with you all will help answer all the questions. So I call this the 4 cardinal principles and 4 obligations of medical ethics. I call it 4 CPO. So we have beneficence that's usually balanced against non-beneficence. Autonomy is usually balanced against distributive justice. And among these 4 cardinal principles, what is the first among equals? You know, when we were younger, it was above all do no harm, It's more like the Hippocratic oath, above all do no harm. And then came evidence-based medicine, and then there was a shift towards beneficence. And then after that, our Chief Justice says, autonomy is the first core ethical principle of prime importance. And when COVID came, it became distributive justice, because if you don't wear a mask, you're forced to wear a mask. So Healthier SG, there will be a tilt towards distributive justice, and of course, beneficence as well. Okay, so we have to sacrifice a bit of autonomy in order to accomplish what the nation wants to accomplish. And then, of course, the 4 obligations, and they will balance against each other. Like veracity, we are obliged to tell the patients the truth. But at the same time, there's certain things we need to keep confidential. Fidelity means we don't abandon patients. We try to manage them as best as we can. But at the same time, we need to respect their privacy. Like if I ask my girlfriend, where were you last night? And the girlfriend says, can you please respect my privacy? Then I'm really wondering where the fidelity is. So there's always this very complicating balance that we need to do. But just remember, for Healthier SG, there's a tilt towards distributive justice and beneficence. Okay, there's a tilt in the direction. We lose some confidentiality because we are actually releasing a lot of data onto the authorities. Okay, just a quick word on what is evidence-based medicine. So evidence-based medicine requires the integration, just watch my fingers, the integration, the little finger, of the best research evidence with our clinical expertise, our forefinger, we do PR, with the patient's unique values and circumstances, the middle finger, and the circumstances, the forefinger in which you are practicing in. So evidence-based medicine requires the integration of everything, not just the best research evidence. We need to put in our clinical expertise, our patient's unique values and circumstances. And to put it this way, it's actually ethical one. Evidence is beneficence. our expertise is above all do no harm, you know, and then the patient's values is autonomy, and the circumstances is usually, I just put it distributive justice. It means, or put it simply, whoever is paying for the whole thing. So now I'll go into the talk now. Healthier SG care protocols. For those of you who are still new, go into the college website, click here for the latest updates, and that will bring you to the primary care pages. And then you click under hypertension or what to read the actual care protocols. So I'm going through hypertension now. Okay, just a quick talk again. When you cannot express it in numbers, your knowledge is of a meager and unsatisfactory kind. So when we talk about evidence-based medicine, it's not usually the guidelines, it's actually the numbers that we want to talk about. So this is from one of the CPGs. And I just want to take note, there are two things here. This is stroke, and this is coronary heart disease. Now, you see, at 90 diastolic, the relative risk of stroke is around 1. But if you can bring the blood pressure down to maybe 84, you actually halve the stroke risk, you know. You actually halve the stroke risk. But for the coronary heart disease, it's not that great, but you can still reduce. At 90, is actually relative risk is 1. And at 84 or at 76, you can actually halve the risk of coronary artery disease. So just keep these numbers in mind, that if you can bring down the blood pressure, you can actually bring down the risk of stroke by actually halving it, by bringing it down to about 6 to 10 millimeters of mercury. So what does this actually mean? This. So if 100 men like you are followed for 5 years, 2 will have a stroke. Now, I took this quote from this Prof. Hanne Honelger, but I think what he refers to is that this 100 men is actually this bunch of people here. So this is from the Singapore Stroke Registry, 2019. I mean, my data may be old, but the principles are all the same. I'm just using this illustratively. So this is the 60 to 69-year age group. And the age-specific incidence per 100,000 population is 400. So if you bring the max down, it will be this one. So if there are 100 men in the 60 to 69-year-old range are followed up for 5 years, 2 will have a stroke, 98 will not. We do not know whether you are one of the sway 2 or one of the very heng 98. Okay? This is what the figures actually mean. Now, if we assume 50% relative risk reduction, okay, if you take antihypertensive medication. So if you take antihypertensive medication, you can jump to another group. Then out of 100 men like you, 1 will have a stroke. So it depends on how sway you are. If you're really sway, you're really the 1. But 99 will not, you know. The trouble is that we still do not know whether you're in the 1, the sway group, or in the 99 group, which is the heng group. So which group do you wish to belong to? Those who accept status quo or those who will take medication? So this is actually the actual meaning behind all this relative risk reduction, you know, incidence, prevalence, or whatever. So personally, this is what it means. So the patient's idea of hengness and swayness is variable one. Okay, it's very unique. Now, let's bring it nationally. So in this particular age band, I just roughly look at this chart and I agak-agak about 500,000, okay? So which means there will be 2,000 strokes a year. And if we can, assuming we can reduce 50% of them, you're talking about 1,040 less strokes per year, you know, for this band alone. And you just work out how many hospital beds we can actually save if we can actually do it well. Okay? And I got this little number here that there are 10,000 admissions for strokes in 2001. I'm not quite sure what's the latest figure, but this is one figure, illustratively. And if we assuming 50% relative risk reduction, we will get 5,125 less strokes. So if we do our job really well, we're actually saving plenty of hospital beds here. Okay, 5,000 plus less strokes. And assuming how many days they stay in hospital and all that, that one I leave it up to the statisticians to calculate. Now I move into this thing. Now this one is also from our CPG. Interestingly, they say enalapril 20 milligram average selling price in NHG, this is many years ago, is 5 cents. Okay, 5 cents. losartan 100 milligrams is 91 cents. And so if we translate to this one, so we multiply 5 cents by 500 times 365, because we need to treat 500 people to prevent one stroke, for example. You multiply by 365 days, that will give you this cost. And so that will bring up to, we need to spend about $9,125 on medication alone, okay, excluding consultation and lab tests, to prevent one stroke. Now, if you use losartan at 90 cents a tablet, we need to spend $166,000+ to prevent one stroke, And at this price, maybe it's easier to just treat the stroke, really. And so the medicine you use, you've got to consider it very, very carefully. You get what I mean? Because if it's a bit too expensive, then it's really no point. You might as well treat the stroke. But if the price is right, we must treat aggressively, so that it's worthwhile preventing the stroke at this price. So financially, this is what evidence-based medicine is all about. You need to know the baseline risk, the extra risk, the relative risk reduction, absolute risk reduction, numbers needed to treat. And you multiply it by the cost, and then you work out which course of action is actually more economical. So this is a quick slide. Now, for those who want to die young, you don't go to school, you smoke, and then you don't exercise your hand, a poor diet, and hypertension comes somewhere here. Okay, comes somewhere here. Now, to choose between stroke or AMI, if you don't want to get a stroke, then you better control your hypertension well, You get what I mean? Hypertension is there. It's very high up here. But if you don't want to die of AMI, right, cholesterol becomes more important. Okay, so if you want to prevent AMI, cholesterol is more important. Then hypertension comes down here. Then you have tobacco. Then if obesity and diabetes is here. But if it's stroke, hypertension is here, household pollution, poor diet, low education, diabetes, cholesterol is all the way here at the bottom. Okay, so if you're scared of stroke, you better take your blood pressure medicine. But if you want to die of AMI, then you just eat whatever you want. Okay, so but if you're aware by AMI, you control your LDL and everything else. Okay, then if you want to achieve immortality, then that one I come under Q&A, then I tell you. Okay. Okay, now we go to the hypertension protocol proper. Don't know how much time I've got. Okay, very quickly. I don't think I need to say much. You're going to read yourself, And this one you all know, the usual clinical method. Sit down, rest for 3 minutes, use the correct size, and do the blood pressure. So diagnose blood pressure if the systolic is 140 or more, or diastolic 90 or more. And then for home blood pressure monitoring, use 135/85 as the cutoff. Okay. Then here, the whole table will talk about, grade 1, grade 2, grade 3, and the action and the recommended action that you can take. So I don't think I want to go through this. You all can actually read for yourself. And then, of course, in history and examination, you look for secondary causes of hypertension, look for target organ damage, and other cardiovascular risk factors. Okay. Then this one is the blood pressure treatment targets. Okay, 140/90 for those 80 and below. And for those a bit older, you allow the systolic to be a bit higher. And also don't decrease the diastolic to below 60. Okay, and there are special conditions like diabetes. Then you want to control the diastolic a bit better. So you bring it down by about 10. So it's 140/80. And then this patients with proteinuria, it's, I don't know why for this one suddenly it's 130 and 80, whereas the rest is less than 140/80. But doesn't matter, you see 1, 2, 3, 4, right? So we see 4 things, these all things will come in MCQ one. So just know these numbers, okay? And then all these criteria will come out, and then at the bottom we probably say all the above. Then the answer will be all the above. So you just need to memorize these numbers. Okay, and these are the recommended care components for healthier SG. You need to take your blood pressure twice a year, weight and BMI twice a year, and annually, your kidney assessment, creatinine and or EGFR, urine albumin or protein creatinine ratio, smoking annually, lipid at baseline, and cardiac assessment at diagnosis before starting medication. Okay, but you can actually refer to the lipid protocols for the rest of the details. Okay, this one they put up very nicely. So so there are 4 classes of drugs, are A, B, C, D. You know, you have the ACE inhibitors, angiotensin receptor blockers, beta blockers, calcium channel blockers, and diuretics. So contraindications, I think you all probably know already. You know, asthma, don't use beta blocker. Heart block, don't use a beta blocker and verapamil and diltiazem. Gout, don't use diuretic. Bilateral renal artery stenosis, don't use ACE and ALB. And this is the one now which we struggle very much. But I suppose if you listen carefully for the renal brie, I don't know. If you hear it, then don't start it. You know, and pregnancy, avoid the ACE, ALB, and diuretics. And this one is actually linked to this thing. When you start ALB and ACE inhibitors, you worry about the deteriorating kidney function, but it's usually because of the bilateral renal artery stenosis problem. Okay, so this is a bit of a problem here we need to deal with. Now, compelling indications, I think you'll probably know. So diabetes, we recommend ACE and ALB. In chronic disease with proteinuria, the same. Heart failure, also ACE, ALB. Diuretics we all know, and bisoprolol and carvedilol for those with reduced ejection fraction. For isolated hypertension in older persons, diuretics is first line, and then after that, long-acting CCBs. And those with myocardial infarction for the first 3 years, you know, beta blockers and ACE. Okay, so this one can read, is in the care protocol. Just go and read. Initial choices, usual stuff. You know, if still cannot control with side effects, change another drug. But if tolerated with inadequate response, add a second agent, preferably diuretic. Okay, then after that, still cannot, you add, then after a while, you cannot make it anymore, consider referring to the specialist. Okay, they need to monitor the ACE and diuretics. This one you probably know, you know, ACE, just watch the serum creatinine and potassium levels after 1 to 2 weeks. And then diuretics are sodium, potassium, and sodium levels, if you're worried. Okay, this one. So A, B, C, D. Okay, quite easy to remember. Everybody loves the CCB. Okay, the ACE loves the CCB, the beta block diuretic loves the CCB, and the beta blocker and CCB less supported by RCT, but still okay. Okay, so these are the lines for good combination. And this dotted line, don't worry too much. It doesn't mean they like each other. It just means that beta blocker and diuretics avoid for patients at risk of diabetes. Okay, the B and the D, avoid for persons at risk of diabetes. Doesn't mean they go together. Okay, this dotted line just means avoid for those with diabetes. Okay, specialist referral recommended when there's malignant hypertension, cardiac failure, or other impending complications. Those are difficult to manage. Maybe 3 or more drugs. And then if you suspect secondary hypertension or hypertension in special circumstances like pregnancy, young children, and all this is all in the write-up. Okay, we quickly go to multi-morbidity. Thanks Ingsin and Sukyang for this slide. So the definition of multi-morbidity is here. And then the patient give a headache means multi-morbidity already. So 2 or more, okay? Complex is defined as 4. And then for condition to be defined as chronic, these are the criteria. Should last more than 6 months, persistent nature, have impact on the patient, etc. And Sukyang like to play bingo, I think. So if you bingo, hypotension actually coexists with a lot of conditions. And then the greatest coexistence is actually obesity. Okay. Okay. I think this one I learned from the Singapore Primary Care Conference, I think a few months ago. It's for simple conditions, you diagnose and you treat, finish. For chronic conditions, which we are dealing with quite often, we need team-based. We need team-based. One person cannot settle everything. But when it comes to complex multi-morbidity, the key word is actually trade-offs. It's trade-offs. This is the famous game, Lisedo against AlphaGo. So what changed the course of the game? Could be the first move that AlphaGo made, or this incredible move that Lisedo made, which you call Kami no Ite, or the hand of God, or this strange move that AlphaGo made, now and at move number 87, that actually caused this commentator, Michael Riedman, to scratch his head. But at the end of the game, this seed actually died. It was a trade-off. Of course, they were aiming for this cutting point somewhere in the center, but the computer, in an effort to get everything, actually end up losing the whole thing. So there's always a trade-off when it comes to complex multi-morbidity. Okay, now we go back to the CARE protocols. It's an MCQ question. Okay, 50% of patients in the early 50s, we have 2 chronic conditions. In the early 60s, we have 3 chronic conditions. And in the late 70s, you have 4 chronic conditions. So when you're talking about people in the 70s, late 70s, it's really complex multi-morbidity already. So the clinical approach would be here. They call it the minimally disruptive medicine now. And then the aim is to reduce treatment burden and increase patient capacity, which I will elaborate later. And number 2, combining all this will be based on this thing called shared decision making. Now, there are many people with different models of how to do this, but I do it ethically. It's the same ethical thing. The acronym now is Hippocrates. Okay, like for example, the patient has got a gangrene of the foot and requires a BK, and the patient don't want to do it. So the first question is why, ask the patient why, and hopefully, and after asking the patient why, sometimes after the why question, the patient may suddenly decide to go ahead with it. If not, then we involve others, and this is what I call distributive justice. Would you like to speak to your children? Would you like to speak to your husband, speak to your wife, speak to your father, mother, insurance company or whatever? And after hearing from them, the patient may actually go ahead with the surgical procedure. Then we need to assess whether the patient is psychologically competent or not. This is mental capacity. And if they don't have mental capacity, we go ahead, act in best interest, chop the leg off. Big gross, but never mind. Then privacy respected. Sometimes you ask a patient why, the patient cannot tell you one, Like if you ask me, why am I running the ultra marathon this Saturday? I cannot really tell you why I'm doing it, Or maybe I have my reason, but I don't want to let you all know. And then we just got to respect it. That's the difficulty about this thing, but sometimes you just do it. Then the next step you can do is offer referral. But once you offer a referral, you actually break confidentiality because you're actually telling the other person quite a lot of things about the patient. Would you like to would you like to have a second opinion from another surgeon? Would you like to have a second opinion from another doctor? That's when we start referring to the specialist, in case the patient don't seem to agree with the treatment they are giving. Or would you like to speak to your pastor, speak to your imam, or you'd like to speak to a fellow amputee? If your fellow amputee, and then the fellow amputee not fellow yet, the fellow has had an amputation done to talk to you. And maybe that will help the patient change their mind. Then the next one is clarity or veracity. You must tell the patients how serious the whole thing is. The blood pressure is going to give an increased risk of stroke. And then you add your diabetes and your LDL and your smoking, you're going to be in big trouble. Is the veracity. Then you talk about risks and benefits and non-malfeasance of both the therapy as well as the non-therapy. And then a firm free choice. That means don't let me pressurize you. You are still free to choose. Then as a doctor, we take a stand. 2 stand, either respect or reject. Reject means refer to ethics committee, get the judge to force an order on you. But most of the time, we respect the patient's decision. And then the next 2 steps is very important because after we take a stand, we always forget this thing called fidelity. That means ensure continuity of care. That means, okay, meanwhile, if I give you IV, antibiotics, I do dressing, is that okay with you? And then after that, finish off the whole thing by saying the status quo can change. That means in case you change your mind, let me know early, and then we can get things going. So the 4 cardinal principles and the 4 obligations are all embedded in this whole acronym. And if you cover everything, generally you're all right already. You're all right already. Okay. Definition of treatment burden and illness burden. That way, there are burdens that's actually caused by the illness, and there are burdens that's actually caused by the treatment. And so in patient A, we know the coping threshold, their capacity, if they're well educated, they got good social support, and they're resilient. And if the medication is not too complicating, and then they can cope with all these problems. But if the medications gets a bit overwhelming, and then they got to go everywhere to get their things done, the whole thing will topple, So in healthier SG, what we're trying to do is actually to make the medications a bit cheaper, so that this little treatment burden can be taken off the patient. And then this fragmented healthcare provision, if you can just switch them on to increase the capacity by having a family physician that will look after them holistically, then the whole thing may not topple as easily as it could, as if we didn't intervene. So they got many diseases, diabetes, hypertension, stroke, and all this. So this one you all go and read, okay? Blood pressure levels 140/80, less than that for those with diabetes, hypertension, and atherosclerosis. And then for chronic disease and stroke, keep it a bit even lower, below 130/80. Same for the cholesterol. So this level here 2.6, and then with all this is 2.1. And HbA1c generally is 7, so should be personalized for elderly. This one is MCQ question. So, if the patient has diabetes, hypertension, and hyperlipidemia, avoid diuretics and avoid beta blockers. ACE and ARB are preferred for control of albuminuria. Fenofibrate can be used for raised TG. Metformin, SGLT2 inhibitors are preferred for these obese patients. And then all of the above. So the answer is all of the above. Okay, very simple MCQ. And then for those with cardiovascular disease, ACE and ARB is preferred. Consider to start and continue beta blockers indefinitely for those with cardiovascular disease. Okay, then you beware of the postural hypotension from all these drugs. Like if you are concurrently using Sorbitrate or Viagra, and then antiplatelets. And then for those with chronic kidney disease, same thing. Maximize ACE, ARB. Titrate hypoglycemics because they are quite susceptible to hypoglycemia. Then use metformin, diuretics, and fenofibrate with caution, etc. And for stroke, beware of postural hypotension. Beware of low HB with antiplatelets. And then antithrombotic therapy is recommended for nearly all patients without contraindications. And then you may want to consider using high-dose statins and ezetimibe. This is all in the notes. You'll just go and read up. It's all in the care protocols. Then because got a lot of medicine, so you just need to go through the process of medication reconciliation. Andrew loves this. So develop a list of current medication. Then you develop a list of medications to be prescribed. You compare the medications on the two lists. You make a clinical decision based on the comparison, and then communicate the new list to the caregivers and to the patient. So there are 5 steps to take for medication reconciliation. For data submission, this is all you need to submit. HbA1c, date. Lipid profile, only LDL only. The rest, up to you, date. Systolic, diastolic, date. Height and weight, date. Then the rest, diabetic retinopathy and all that. But don't worry, I think if the CMS that you're using is worth its salt, right, they will tell you what is done and not done. So for example, I went to visit my CMS provider on the 6th of June. And this is the example he gave. This is the patient's name. And these are the stuff that need to be done, like the LDL you need to do once a year, weight you need to do twice a year, blood pressure you need to do twice a year. And the actual value is all here. So at one glance, you know that all these things are missing. And if you have done it, the CMS should be able to tell you that you have done it or what's not done. So you should know, it will trigger you to do what you need to do. So don't worry too much about this thing. Then this is, I think I visited him before the first briefing we had last Saturday on the health care plan, right? So this one we got to thank Roy Tiao. Roy, you don't have to control print screen. You just listen to this. We want to thank you. Clapping. So I think the CMS provider told me that Roy actually approached him to work out this care plan. So they are working on some algorithm that when you put hypertension, hyperlipidemia, and diabetes, and somehow or another, it will auto-fill a default care plan for you. And then if you need to amend, you can actually amend according to the patient's unique circumstances. Okay. And then you can actually copy the previous care plan if you want to. So you can actually look at the care plan that you have done in February, in August. And if you want to copy, just copy and paste, and then everything will come into here. But if you want to change anything, you just change. But I think Roy is helping them to work on an algorithm to sort of pre-fill most of these things. And then the rest, you all just go and do yourself. Screening, he said, is not connected yet, so I don't know what it is all about. Vaccination, if it's connected, you just need to order and click. And then you click pneumococcal. If it's not done yet, you click pneumococcal. This one will flow automatically straight to the dispensing. So you don't have to go to dispensing to dispense it again. And this one, for investigations, this one got thank Lim Chen Chuan. I mean, they're all PCN leads, and they're doing a very good job trying to get all these things going. And then they've been doing the PCN thing for so many years. I think they roughly know what's needed. So Chen Chuan actually approached the CMS provider. Like, see this thing, if the last DRP is not done, you just need to click order. And then this order will straight away go to either the Diabetic Society of Singapore or to the PCN or whatever. And then there, the staff will keep track of all your orders that you have made. That means you actually spoke to the patient and the patient is keen to do. You just click this button and all the patient data will just go straight to the organization. And the organization will just pile up all the people. Either they call them to make appointments, or for my case, I think every month they will come here for, every 1 or 2 months, they will come here for 2 days. They will bring the DLP machine and then they will do the DFS and the nurse counseling at the same time. But I left it to the PCN to go and call my patients and align the 7 patients they need to do for that day. And they will all come down to my clinic to do. Of course, it's a big cost because I end up seeing patients in my pantry, but no choice. They need to use my consultation room to do all this work. But that's one way of getting the patients to go for their DLP, DFS, and the rest. And I add an extra goodie because I tell them I'll pay for them from whatever thing that the PCN will give to me. So it makes it easier, and it's this burden thing. We make it less burdensome to the patient. They are more likely to adhere, comply. Okay. Then after I think it's finished, you just print, and then the printed health plan will come out. Once you click enter, straight everything will flow into the handphone. And when I went there, I said, hey, the current DLP thing, your current field is only date done, yes or no. Then I told them, hey, in the Healthier SG is bopake, if you just key date done and done, you don't get any points. You need to actually key in the result of the DRP. So I told them to go to the college website, click to Healthier Care Protocol, click and take a look at what is in the care protocol. And by the night, they actually said they put it in for me already. So it's there, so you just, and this one I leave it up to the DLP people to click for me. After they've done the DLP, if it's diabetic retinopathy, they will click the result. And then that will, or no anomaly detected, and that will give you all the points for Healthier SG. So the message I want to put across to you is speak to your CMS provider and tell them exactly what is needed. Okay, and they will tweak it for you so that everything becomes easy. So I think I went to visit him on the 6th. Very nice because his office, I can see my clinic from his office. And just speak to them. And they will tweak the system to, and according to him, he says, whatever lab result, everything will flow there. Whatever you type in the BMI, the height and weight, everything will just flow automatically. You don't have to do any extra clicking. Okay? So they will continue to improve the CMS. So that's the main message I want to tell. Speak to your CMS provider and tell them exactly what you want, so they will make your life easier. So with that, I thank you for your attention, and it's time for questions.
Thanks, Julie.